Hi, my name's Amy Wolstenholme. I'm a school-based PT, and I want to share important information with parents of children with cerebral palsy and cerebral palsy-like disorders. I suspect with your child's diagnosis, hip surveillance was discussed and even planned for. This is an opportunity to explain the importance of it. Our objectives today are that you'll have a clear understanding of your child's GMFCS level and how it relates to hip surveillance. You'll understand the importance of regular hip imaging and demonstrate an understanding of how to advocate for your child with regards to their hips. Everyone here generally knows what cerebral palsy is. The definition is important because the abnormal muscle tone and pull that come from the diagnosis can cause the hip displacement, which is at the heart of this lecture. Cerebral meaning brain, palsy meaning weakness or impaired muscles, can be part of the body or the whole body, and it can be spastic or low tone. When children are born with cerebral palsy, the neurological symptoms do not progress. It is not degenerative. That said, the neuromuscular status of kids with CP changes as a result of changes in muscle tone. Many kids with CP are born with low tone, and the increased tone in certain muscles develops as the kids develop movement patterns that function for them. An example of this is when children throw their heads back to roll and roll with their extensor muscles. The extensor tone increases while the flexors or abdominals remain weak and become overstretched. The roll is functional for the children, so they continue to do it and continue to perpetuate the overstretching of the belly muscles. Your doctor has classified your child based on the gross motor classification system. The level indicates the functional mobility of that your child demonstrates. The levels go from 1 through 5, with 1 being the most mobile and 5 being the most dependent. Your PT has likely included this in your child's evaluation or reevaluation report. Bear in mind, this is a physical descriptor and not an indicator of cognition. The importance of knowing the GMFCS level is that it helps to predict functional abilities as well as the potential need for surgery. Level 1 and 2 have a lower risk of need for surgery, as weight bearing and walking helps with the hips to develop. Levels 3 through 5 are at higher risk because despite interventions such as standards and gait trainers, as well as short distance ambulation, the hips are at higher risk for displacement. This chart indicates the trajectory of the GMFCS levels. Between the ages of 2 and 7, gross motor progress generally levels out. This GMFCS levels demonstrated accuracy from ages 2 to 3, with most children being diagnosed with CP by the age of 2 in the United States. Doctors want to keep a close eye on the hips of these children. The hips are at high risk of hip dysplasia, which leads to subluxation and untreated dislocation. The abnormal muscle pull in these kids create forces which put them at higher risk for hip displacement. The kicker is that the symptoms of these hip issues are completely absent. They are painless, and the only measurement for the degree of displacement is the migration percentage, which is calculated by X-ray. Pain only begins when the hips are fully dislocated. At this point, the hips cannot be reconstructed. This is why hip surveillance or routine imaging is recommended at the time of diagnosis and to continue every 6 months to a year through adolescence. Monitoring the hip migration allows doctors to see the changes and make recommendations for intervention. The ultimate goal being to maintain function and improve quality of life. This is a quick visual depicting the options which arise from imaging. This may be a bit technical, but your doctor will let you know what percentage your child is showing. Surgical interventions are considered when the number is greater than 30%. Muscle releases have been a traditional option to reduce the pull on the hips and buy time until a full reconstruction would be necessary. More recently, surgeons have been exploring proximal femoral guided growth. If your child is young, under age 6 through age 10, depending on your doctor, and between 25 to 30% hip migration, they can do proximal femoral guided growth. Over 30% and over age 10, reconstruction or derotation osteotomy is recommended. At 100%, full dislocation, children need a salvage surgery to reduce pain. If a child has a migration percentage of 30 or greater before the age of 6, muscle lengthenings of the adductors and psoas are common to prevent hip dislocation. By reducing the spastic pull on the muscle, they can reduce the migration percentage. This is an example of how the hip position changes after the muscle lengthening. Proximal femoral guided growth, as I mentioned earlier, is a newer option for children and has shown success in preventing the need for the derotational osteotomies later in life. This is a comparably simple procedure in which a screw is inserted through the neck of the femur into the head of the femur, encouraging the bone to grow around it. This creates an improved angle of the neck of the femur. This also reduces the potential to sublux. It has been shown to be more effective than muscle releases in reducing the need for surgery. This is a newer procedure that is best done before the age of 6, but has been successful up to age 10. Students who fit the criteria would carry a GMFCS level of 3 to 5 and be between the ages of 4 and 10 and have a hip migration of 25 to 50%. The earlier the better for this procedure. The risks of the side effects are much lower due to the minimally invasive nature of the procedure. The children can get back up on their feet quite quickly after this. The derotational osteotomy is typically done after a hip migration percentage of greater than 30 degrees has been noted. It might be earlier if the child is ambulatory and the subluxation is causing a leg length discrepancy, which impacts their gait. The osteotomy can improve functional outcomes as well as prevent the pain of full dislocation. The surgery is complex and has a long recovery. There is a higher risk of complication with the surgery, at least in part due to the medically fragile nature of many of the candidates. You can see the extensive hardware used. This can be removed if it is causing pain after about 18 months after the surgery. The incidence of dislocation after this surgery is approximately 5%. As the hips dislocate, the head of the femur changes shape so significantly that it can't be restored. As a result, surgeons perform a salvage surgery as a palliative management to reduce pain and improve quality of life. This session was to focus on the need for hip surveillance for prevention of dislocation. Regardless, it should be known that PTs are using all therapeutic interventions at our disposal to support hip health by using evidence-based practices. When students have CP, therapists are quick to add a standing program to their school day. Programs are typically an hour per day and are recommended if a child is not walking in the classroom. Students should have as many opportunities to stand actively as they can. This means using their legs to transfer if they can weight bear instead of being lifted. When children are little, lifting is often the easiest and quickest option, but by encouraging the active use of their bodies, we can help stave off the need for surgery. As they get bigger and harder to lift, they will still have the tools they need to actively participate in transfers. We also use hands and knees, tall kneel, half kneel, things like that to promote hip health and development. While these are good core engaging activities, we use them also to encourage weight bearing in a functional manner and go through the developmental sequence. This helps to encourage bone growth. My hope is that this is a reminder of the importance of hip surveillance, and it will help you to take an active role in your child's hip health. When your child has multiple complications and issues from their disability, it can be easy to let an appointment for a routine x-ray slide because your child isn't in pain. The reality of the silent situation cannot be understated. It is never too late to get the next x-ray, so don't wait until next year. Despite knowing the benefits of hip surveillance and clinical guidelines recommending them, the parents are the key players. We need to identify barriers to getting the x-rays done and support families where we are able. Some examples of barriers would be who schedules the appointment and takes the child? Is this an easy process through your provider? Do you have to wait for callbacks and play phone tag? Do you have transportation for your child? Do you get feedback immediately on the x-rays taken? Do you have a chance to ask questions about what the x-rays mean? Do you know what your child's migration percentage is? Does your child need sedation for x-rays? I appreciate your time, and since this is a video, I've left my email here. If you have any questions, I would love to hear from you and to get some feedback. I have my references here. And my last slide is a survey. I'm hoping that you'll be able to fill this survey out for me, as I am using this information for my doctorate of physical therapy at Arcadia University. I am doing some research on this. Your survey results will be anonymous, but I am interested in finding out if this information was helpful to you. Thank you so much for your time, and please fill out my survey. Thank you.